So again, thank you, and this is my disclosure. So selecting patients for focal therapy, certainly intermediate risk prostate cancer would be the most suitable candidates for focal therapy. However, some patients on low risk prostate cancer and some on high risk prostate cancer would also be candidates for focal therapy. This manuscript reviewed the literature the past 20 years, since 2096 to 2015, and they found 37 articles reporting 3,230 patients. All of those, only 9 articles actually reported high-risk prostate cancer treatment for focal therapy, including like 5% of the patients. And most of these patients, 139, 140 of them, are from the code registry. So if you exclude this, only 38 patients were reported to the entire literature since 1996 to 2015, according to this review. What they found was focal therapy overall, HIFU or cryoablation, and all the others. They are safe with low impact on continence and potency. However, oncological outcomes is still yet to be challenged or compared with standard of care. Certainly, a critique at this point was that many of these patients would not necessarily be treated, that they were just treating patients with low-risk cancer and actually not real benefit. Then we started seeing 2019 series of manuscripts coming up, and this is one of them. This manuscript from UCL and reporting 1,000 patients on focal HIFU. And you can see over there that vast majority of the patients, 80%, have grade group 2 or higher. What is interesting is that when they report their series, you see how it increased the number of patients with 3+4 and how decreased the number of patients with 3+3 Gleason 6. So it's probably reflecting this debate and the discussion within the field. Now, how about intermediate and high-risk prostate cancer? This last year, this manuscript was published from Canada. There's a multi-institutional study in 3 centers, 150 patients with biopsy proving unilateral cancer. Patients underwent partial gland ablation. In the 2 years follow-up, still a short follow-up, about 37% of these patients had clinically significant cancer on rebiopsy. Vast majority of them were intermediate and high-risk prostate cancer from the begin with, more than 80% of the patients. Salvage treatment was required in 25% of them, but whole gland treatment was avoided in 81% of these patients. Again, in 2 years of follow-up, still a short follow-up, but we are talking about a higher risk cohort. And then this manuscript is interesting. There's 600 patients from UK. There's a prospective registry with 9 centers, and they really put high-risk disease patients here. You can tell there are patients with Gleason 9, there are patients with T3B disease, and PSA up to 30. So this is a large cohort, multi-century, and with patients with intermediate and high risk up to 85%. The endpoints they analyzed in terms of oncological outcomes was radical, failure-free survival defined as radical or systemic therapy, metastasis or cancer-specific mortality. And several templates were allowed, including cancer on the other side, small volume, low grade. And the results are pretty remarkable. If you look, patients with intermediate risk and high risk prostate cancer, they have 5 years failure-free survival by that definition, 88% and 84%. It's really, really remarkable results. However, keep in mind that patients with high PSA to begin with and T3 stage had higher chance of failure. So again, we are treating intermediate and high risk, but these patients, yes, they do have higher risk for failure. How about focal cryoablation? Again, a series from the UK, 122 patients. They included only patients with high and intermediate risk prostate cancer. And you can tell that 30% of the patients had high-risk prostate cancer. Again, they did cryoablation. Most of these patients had anterior tumors. They were selected for ablation with the anterior tumors. Follow-up is still short, about 2.5, 3 years, and the outcomes were pretty much the same. Failure-free survival, transition to radical treatment, whole gland ablation, systemic therapy, metastasis or death. And what they found was, again, very remarkable. Still in 36 months, estimated free survival in 3 years was intermediate risk 93% and high risks 85%. So again, results are consistent according to the definition, even using different cohorts, using different technologies. We also looked into our data on patients undergoing hem gland cryoablation, and from 160 patients, 82% of the patients had intermediate and high-risk prostate cancer. The endpoints we used was consistent to the literature. Radical treatment, treatment failure was radical treatment, systemic therapy, metastasis or death. And what we found was in 5 years, 83% of the patients were free of failure and intermediate risk and 78% by high risk. It's also interesting here that, again, if you're using intermediate and high-risk patients, treating these patients, keep in mind that grade group 3 was independent predictor for failure, and we found very strong PSA density. If you're treating your patients, considering focal therapy for your patients, look at the PSA density. It's a very strong predictor for failure. There are a lot of data on PSA density in the literature. Now, we also reporting our initial cohort. This is the first cohort of HIFU from US. This is initial series of focal HIFU as a primary treatment from the United States. And again, we analyzed the patients that underwent primary hemi-HIFU in 2 institutions performed in the United States. Again, HIFU was cleared by FDA for tissue ablation in 2015, so do not expect longer follow-up. But the definition for failure was the same. We kept consistent, but we included, because the cohort is young still, we included also biopsy as a treatment failure, not only radical treatment and other parameters that were there before, but we included biopsy as well, to be fair. And we reported 100 patients, 70% of them have intermediate and high-risk prostate cancer, and in a median follow-up of 2 years, that's what we have. Radical treatment was avoided in 90% of these patients with intermediate and high risk in 2 years, similar to the cohort from Canada. They have reported 81%, and failure was 72% for these patients according to that definition. What is interesting now, we are, for these patients undergoing focal therapy, we are offering them as a proof of concept lymph node dissection at the same time of focal therapy. So for patients that have increased risk by the nomograms of 5% or higher, we are offering them focal therapy if they agree, and then lymph node dissection. This is based on the NCCN guidelines. As we perform radical prostatectomy, we should consider at least pelvic lymph node dissection if they have chance of metastasis more than 2% by the nomograms. So use the same idea, the same concept we're offering for the patients. We actually did this. This is a concomitant focal HIFU and robotic pelvic lymph node dissection that we performed in 7 patients. And what is interesting here is that you see median risk of lymph node invasion is 11% by the nomograms, number of nodes retrieved 15%. And this particular patient here with lymph node, chance of lymph node metastasis of 5% only, intermediate risk, here's the PSA, here's the grade group, and he had 2 positive nodes. We, of course, do metastatic workup for these patients. However, the images we have currently are not so accurate. We do not have PET PSMA that could be helpful. I don't know, don't have experience with it, but this interesting that this patient had a node metastasis. We would all agree that we should do randomized clinical trials to compare focal therapy with radical treatment or with standard of care. However, it's not so easy. As you can see here, there's an abstract from group from Norway, from Bacco and his team. They try to randomize patients for focal therapy versus radical prostatectomy. And in fact, what they found was, surprisingly to me, that 11 patients that were assigned for radical prostatectomy actually refused radical prostatectomy and demanded focal ablation. So no patients from focal ablation rejected the randomization. And it was interesting here that comparing, during a randomized clinical trial, comparing focal therapy versus radical prostatectomy is difficult because patients cross over from radical prostatectomy to focal ablation. So focal therapy is involved field, it's safe, it's feasible, reproducible, functional outcomes, incontinence are good. Cancer control, we need to define the endpoints and compare with standard of cares. Larger and multicentric cohorts are now being reported with longer follow-up, up to 5 years. Low intermediate risk could be the sweet spot, but we're seeing more and more intermediate and high-risk patients being evaluated. Thank you.
Yeah. Thank you.